Hi everyone, I'm Dr. Arash Shahraman, an endodontist, oral epidemiologist, and professor at Kerman University of Medical Sciences. Welcome back to the channel. To our returning viewers, your engagement is what keeps this channel going. If you are new here, you've joined at the perfect time. In this video, we are going to review 7 exciting papers about endodontic treatment published in July 2025. We have some heavy hitters today, including a debate on single cone versus one vertical, new data on regenerative endodontics versus MTA apexification, and a very interesting look at which patients are most at risk for hospitalization in endodontic field. Grab your coffee and let's dive into the evidence. First, let's talk about a nightmare scenario for every dentist, the flare-up. We know that pushing bacteria out of the apex is a major cause, but does your file system actually make a difference? A systematic review published in the July 2025 issue of the Journal of Endodontics by Monteiro from Brazil looked at exactly this. They compared rotary, reciprocating, and manual instrumentation. They found manual instrumentation caused significantly more bacterial extrusion compared with engine-driven systems. And also, when rotary and reciprocating systems were compared, the results were mixed. However, in general, rotary systems extruded similar or slightly greater amount of bacterial than reciprocating systems. So, what does this mean clinically? If you are still using hand files for the majority of your instrumentation, you are likely pushing more bacteria into the preapical tissues. Switching to engine-driven system is a safer option and may help minimize bacterial extrusion. Next up, let's look at obturation. We all love the speed of the single cone technique with bioceramic sealers, but are we sacrificing success for that speed? Dr. Al-Zubi and colleagues from Kuwait published a randomized control trial comparing sealer-based obturation using a bioceramic sealer against traditional one vertical compaction in Journal of Endodontics. They followed 195 participants for 1 year, and what were the results? About comparing the success rates, they found no significant difference in success rates between the two groups, whether they looked at preapical radiographs or 3D CBCTs. And what about the treatment duration? This is the big one. The bioceramic group was significantly faster, taking an average of 85 seconds to obturate, compared to 160 seconds for one vertical. Speaking of obturation, what about those difficult open apex cases? Controlling the material is always a challenge. A study by Wang from China tested a novel apical barrier technique. They used the patient's CVCT to design and 3D print a custom plugger that perfectly matched the canal shape. 47 patients with 50 teeth meeting the inclusion criteria of large root canals and incompletely developed apical foramina were enrolled in this clinical trial. Now, let's look at the results. First, quality. The 3D printing group showed significantly less overfilling compared with the traditional technique. Second, efficiency. The process was incredibly fast. The novel technique took about 38 seconds to complete the fillings, while the traditional plugger required nearly 100 seconds. So, what's the clinical bottom line? These findings point toward the future of endodontics. Personalized 3D printed instrument can turn unpredictable cases such as wide open apices into much more predictable treatments. Now let's look at pediatric cases. When treating necrotic immature teeth, we usually decide between MTA apexification or regenerative endodontic treatment. We know regenerative treatment helps the roots grow. But is that new root structure actually strong? Dr. Ali Nosrat and his team from United States published a fascinating clinical study. A total of 6 volunteers aged between 9 and 14 years participated in this study, each providing a pair of mandibular or maxillary premolars with normal pulp and preapex planned for extraction due to orthodontic reasons. They treated pairs of immature premolars, one with MTA, one with regenerative endodontic treatment, and later extracted them to test the root's hardness. Here are the key findings. First, volume. The regenerative endodontic treatment group showed a significant increase in root volume. Second, hardness. The newly formed tissue in the regenerative endodontic treatment group was significantly softer and had a lower elastic modulus compared with the dentin seen in the MTA group. So what's the clinical bottom line? Regenerative endodontic treatment does promote root growth, but it's important to remember that the tissue form is cementum-like or bone-like, not true dentin. Structurally, it is different and softer than the original root. Let's shift our focus to microsurgery, specifically apicomarginal defect, where the buccal bone is lost all the way from the apex to the crown. Do we just clean it or do we need to regenerate? Dr. Sharma and colleagues from India published a randomized controlled trial in July 2025 in the Journal of Oral and Maxillofacial Surgery. They compared doing microsurgery alone versus microsurgery plus an allograft and a collagen membrane. And here are the results. At 1 year follow-up, the guided tissue regeneration group had significantly better labial alveolar bone regeneration, about 17% coverage compared to only 4% in the control group. Clinical bottom line: if you have an apicomarginal defect, don't just do an apicoectomy. Adding a membrane and bone graft is essential to bring that labial bone plate back. Staying on surgery, what material should we use for the root end filling? MTA has been the gold standard, but newer bioceramics like EndoSequence handle much better. A systematic review by Pablo C. Ibanez Aravena and colleagues from Chile in the Australian Endodontic Journal analyzed 5 studies comparing these new materials against MTA. The meta-analysis showed no statistical difference in success rate between new bioceramics and MTA. Clinical bottom line: since the success rates are identical, you can choose based on handling. If you find premixed bioceramic easier to place than MTA, go for it. The evidence supports you. Finally, let's end with a pop quiz question. Which specific tooth and condition is statistically most likely to send your patient to the hospital with a severe infection? A maxillary molar with a failed root canal. B, a mandibular molar with a primary infection. A study by Siva and colleagues from Sweden published in Journal of Endodontics analyzed 9 years of hospitalization data. The answer is B. They found that the mandibular molar with primary apical periodontitis was the #1 cause of hospitalization. They also found that patients who were smoker or had psychiatric disorder were at significantly higher risk. Clinical bottom line: when you see a hot mandibular molar in a smoker or a medically compromised patient, don't delay treatment. These are the cases that spiral out of control the fastest. And there you have it, 7 papers from mid-2025 that directly impact how we treat our patients. To recap: 1. Single cone bioceramic obturation is efficient and successful. 2. For large surgical defects, use membrane and graft. 3. Watch out for necrotic lower molars in high-risk patients. 4. Use premixed bioceramics as retrofilling material. 5. The tissue form in regenerative endodontic treatment is cementum-like or bone-like, not true dentin. 6. Personalized 3D printed plugger is novel apical barrier technique and is useful in treating necrotic open apex cases. 7. For instrumentation, switching to engine-driven systems especially reciprocating one is a safer option and may help minimize bacterial extrusion. I hope you enjoyed this update. If you found this video valuable, please hit that like button, subscribe, and ring the notification bell. I'm Dr. Arash Shahrawan, and I'll see you in the next video.